Module 3, Infection Control. So before we get started, it is very important that you understand why infection control and prevention is so important to nurses. So as a nurse, you're at the front line. You pretty much spend more time with the patient than most other people on the healthcare team, including their physician. So as nurses, we have the opportunity to really prevent infection, to recognize things that could make a patient more at risk for infection, and implement interventions that could really save a life. Infection control doesn't only stay within the hospital, it goes beyond that. It can be in any clinical setting, even in your home. So it's really important that you're thinking about this concept broadly and remember how important your role is as the nurse in infection control and prevention. So what is an infection? So all of us have either had an infection ourselves or maybe known somebody who has an infection, maybe a child with an ear infection or maybe a UTI, urinary tract infection. So we're familiar with those words, but what exactly is happening physiologically within the body? So let's talk about that. Okay, so infection is invasion of and multiplication in the body by a pathogen, which is a microorganism capable of causing disease. So a microorganism can be pretty much anything like bacteria, viruses, fungus, parasites. It really doesn't matter what it is. We call it an infection when they get into the body and they start reproducing. So not all microorganisms can cause an infection in our body. We are surrounded by pathogens. We're surrounded by tiny microscopic microorganisms, and they live on our body, they live around us, they live inside us, but they all don't cause disease. Okay, so an infection has to be a specific type of pathogen that actually is going to cause a disease in our body. Now, when it comes to policy and procedures related to infection control, there are guidelines that we have to follow. And just like anything else we do in nursing, we use evidence-based practice. We do not make random decisions. We don't do things because we think it's going to work or it looks like it works. These things need to be researched and tested and proven to provide the best patient outcome. So agencies such as the Joint Commission, CDC, American Nurses Association, Agency for Healthcare Research and Quality, or AHRQ, CUSIN Institute, all of these organizations aim for the same thing: safety with our patients. We don't want patients to die in our care. We want to prevent things from happening. That is our goal. So we're talking about infection control. So the goals of infection prevention and control is to protect patients from infections. So if a patient comes into the hospital, we shouldn't be giving them an infection. We want to protect us and others from diseases. So if a patient comes in with some type of infectious disease, we want to make sure that we don't get it, and we want to make sure we don't bring it home to our families. We don't want patients to infect other patients also, so we want to reduce the transmission of infectious diseases. We also want to reduce the severity of illness and complications resulting from the infection. Okay, so maybe the patient did get an infection somewhere in the community, came into the hospital, so we want to try to reduce that progression. And of course, while we do this, we need to meet professional standards and guidelines. Some terms that you should be familiar with are healthcare-associated infection and nosocomial infection. So healthcare-associated infection refers to infections that are associated with healthcare given in any setting. So it's anywhere a patient goes to receive care, not only the hospital, but maybe a clinic, an urgent care, doctor's office, skilled nursing facility, assisted living, any setting. Okay, it's just healthcare associated. Then we have nosocomial infection. This usually refers to infections acquired in the hospital. But if you have a patient in the hospital and they say they have an HAI or healthcare associated infection, those two words are used interchangeably. So just to note, HAIs are the leading complication of hospital care and one of the 10 leading causes of death in the US. So that is pretty significant. If you can imagine that people are dying from something that probably could have been prevented, that is scary. It's more scary when you try to picture yourself in that position or your loved one. So imagine that you have some type of infection. You have a stomach bug. You go into the hospital and then you get another infection and you die from it. When you think of it like that, that is pretty serious, that is pretty scary. So that's how you have to think of it, because it's so important, and that's why we have to talk about it so much, because it's preventable. Continuing on with professional standards and guidelines, we have the Centers for Disease Control, or CDC. Now the CDC monitors worldwide disease threats. It detects, it tracks, it uses lots of technology, research, analytics to provide and deliver information to prevent and control spread of disease to us. So we consider the CDC a reliable source, and whenever there is something like a pandemic, epidemic, we look to the CDC for guidance. Okay, so when COVID hit, that's exactly what we did. The CDC was the one telling facilities, hospitals on recommendations on how we should be, managing this. Granted, COVID was something brand new, so did it go perfectly smooth? Absolutely not. But nonetheless, the CDC is part of our resource for professional standards and guidelines. And then we have the U.S. Department of Health and Human Services. So one of their main goals is to keep patients from acquiring HAIs, or healthcare associated infections, while receiving care in any healthcare facility. So there are certain things, procedures, certain infections that are very, very common in the hospital and poses a great risk for infection. So that's what they really try to keep an eye on, and they really try to instill protocols that are to be followed to prevent these infections. So we see here on the list, we have central line is the top one. So patients who have central lines, now you'll learn more about central lines a little later, probably in Med-Surg. But a central line is a catheter. It is intravenously inserted, and it goes all the way to the heart to deliver medication or IV fluids. So if you can imagine, that is like a direct line inside the body, not just inside the body, but all the way to the heart. So very important that we are always using sterile technique when we're accessing that line and when we change the dressing, and only patients who absolutely need it should have one put in, because there is such a huge risk of infection. So if a patient gets a central line infection, we are going to call it a CLOPSI, central line associated bloodstream infection. That's a CLOPSI. So when you're at clinicals, or maybe if you were at the hospital for something, if you look around, there's usually like flyers or posters on all kinds of initiatives to prevent this. So if you see CLOPSI, that's what it is. Then we have surgical site infection. So here the patient may come in with intact skin, right? No openings, no cuts, goes to surgery. Now the patient has an incision that we gave them, right? So whatever surgery it is, they have an incision. So now we know their skin is no longer intact, patients at risk for infection. So those patients, we need to take extra care for. We need to assess the patient periodically. We need to make sure there's no signs and symptoms of infection. We need to make sure the patient is taking the prescribed medication, like antibiotics, if applicable. So there's a protocol in place. These things have been researched for a very long time. So the protocols we have in place are evidence-based and they work. It's just we have to be consistent. If you were the nurse taking care of one of these patients that just had surgery, and say you were working your 12-hour shift and you were meticulous, you washed your hands, you didn't cross-contaminate, you did your assessment, every 2 hours when the patient came back from surgery, you made sure you did everything by the book. Well then, when you go home, and what if the next nurse comes in, didn't wash her hands as frequently, touched dirty things on the incision with her gloves, things like that, there goes all of your hard work. So we have to be consistent. We cannot cut corners. We need to follow policy and procedure because it's there for a reason. That patient who had a simple surgery, if they got an infection, they could potentially die from it. We don't know. It's happened, and they can become another statistic, Really important that you take this seriously and you understand the importance of following procedure. Now let's talk about how an infection occurs. So a patient is sick with pneumonia. Well, how did that microorganism get inside the body? How did this even start? How can we prevent it? What could we have done, educated or interventions to stop this from happening, before the patient got sick? So we call this the 6 links of infection. So this picture is from your textbook. Okay, we're going to go through each chain. Okay, it looks like a little chain because they're all connected. So these all have to happen. All of these links need to be in place in order for the infection to be transmitted from one individual to another. So if you look at it, you're like, wow, that's pretty, that's a lot. Let's say we have 1, 2, 3, 4, 5, 6, right? All the way around. If we can just stop one of these links, then the infection wouldn't have been transmitted. So if you look at it that way, we do have a lot of opportunities to prevent infection. We just need to be aware of these things and we actually need to do it. So we start with our infectious agent. So a couple terms that you should be familiar with: normal flora. So normal flora live in our intestine and they help with a lot of different things. So they're good. Okay, normal flora are good. Then we have transient flora, which are also microorganisms that are in our environment we come in contact with, either by touching them or maybe another person. But those type we can wash off. Transient meaning they don't live on us, they're temporary. Then we have resident flora. So these are microorganisms that live on our skin and we live symbiotically, and they help us, we help them, and we're all good. So infectious agent also could be bacteria, virus, fungus, parasites. Okay, you look at this little cartoon here, this cartoon hand with the little germs on it. That's our environment. Millions, probably billions of microbes and pathogens all around us, some living on us, some living inside us. Again, some of them could potentially be infectious to us. If you look at this picture here on the left, you can see how many different flora, bacteria, live in and on our body. So it's a ton. So when do things change? Well, normal flora may become pathogenic or may cause infection if the patient is already immunocompromised. So we're going to talk about this a little later, but if the patient already has an issue with their immune system, then the normal flora might become a problem. Sometimes the flora that are living in a specific area on our body, if they travel to a different area, then they can cause problems because they're not supposed to be there. Remember, our body's always in balance, so when something changes or becomes there's an imbalance, then things happen. So the example given on this slide here, we have E. coli bacteria. It lives in our bowel. That's where its home is, and it's good there. However, if stool, or you have a bowel movement and some of that stool that has the E. coli in it makes its way up to the urinary tract, then that can cause an infection. Okay, so that flora is okay in the bowel, but it causes an infection in the urinary tract. That's an example of good flora gone bad. So continuing on with this infectious agent. So we have been using the word pathogens. So pathogen are microorganisms that are capable of causing disease. Again, most common bacteria, viruses, fungus, and then we have some less common here. So once a pathogen enters our body or enters the host, it doesn't automatically become an infection. There are a few factors that will determine whether that little microorganism starts to multiply and starts a problem. So these things are virulence. So this is its potential to cause disease. So some microorganisms, are not that mean. They just kind of hang out. They're not that aggressive, but then others really, really pack a punch. So they're virulence. Then we have the host environment. So this is how well that environment is. Is it nice and warm and has nutrients, or is it cold and dry? So it really just depends. But if that host environment is inhabitable, then it has more potential to become an infection. Then we have the number of organisms. So the more there are, the more potential it's going to turn into an infection. Then we have host defenses, talking about the patient's immune system. Are they a little baby newborn? Are they an elderly patient whose immune system isn't the greatest anymore? Then they might be susceptible to an infection that you and I may be able to fight off. Okay, so those are the four main factors that determine whether that infectious agent is going to actually turn into an infection in the body. Reservoir. So reservoir is like where the pathogens survive and live and multiply and become, a big infection. So living organisms are a reservoir. We are a reservoir, human body. Most pathogens, most microorganisms, like a warm, moist environment. So we have a lot of locations, a lot of options for that meet that criteria. Then we have carriers. So carriers are people who don't get sick themselves because maybe they're able to fight off these microorganisms. However, they can pass them to others. They can transmit them to others. Okay, so reservoir, we have our living organism, which is us, the human body. But then we have non-living reservoirs. So pathogens also live in soil, water, even in food. For example, food that you may have cooked at home, you ate dinner, you leave it on the table or in the kitchen overnight. That food is already filled with bacteria and microorganisms. So you may not want to eat that food because now it's like a huge reservoir. In the hospital or in healthcare facilities, non-living reservoirs examples are sinks, toilets, the bed rails, bed linens, equipment, anything like that. Anything the patient has touched, we consider a non-living reservoir because they could potentially harbor all of these microorganisms. So what do pathogens need to grow? I'll give you a minute to think about this. Okay, so remember this is just an overview, but this is what most pathogens need to survive. First on the list is nutrients. So these microbes need to be able to use our body's balance of nutrients, electrolytes, pH, and temperature. So our normal temperature is 98.6, 98.7. So if you have a microbe that tries to enter our body that thrives in a temperature that's 94 degrees, then it's going to die. It's not going to want to live there. If you have a microbe that likes an acidic environment and it comes into our body and we are not acidic, then it's not going to want to live there. Okay, so these nutrients, the microbes have to be able to use us in order to survive. Moisture. So when things are wet, moist, it really kind of attracts those microbes. So like wounds, the perineal area, our respiratory airway, our throat, our nose, all of those places, microbes like to hang out. Temperature, oxygen. Oxygen is not required for some microbes. We have aerobic and anaerobic organisms. pH and electrolytes, again, our pH is supposed to be 7.25 to 7.35, and anything below that is acidic, anything above it is alkalytic. So let me give you an example of why it's important that you need to know this. So as you will learn, when the body is stressed, we make more stomach acid. It's just something that happens. So when patients go to the hospital, we consider that a stressful environment. It doesn't matter why you're in the hospital. If you had surgery, if you had some kind of trauma, even more so, your body is going to produce more stomach acid. So if you have too much stomach acid, you could potentially develop an ulcer. So it is for that reason that when most patients come to the hospital and they're very sick, you will be prescribed an antacid of some kind. And that's prophylactic just to prevent that acid buildup so that you don't get an ulcer while you're in the hospital. So here you are in the hospital getting this antacid. That antacid is going to, reduce the acid in your stomach. So that means your pH is going to change in your stomach. You're no longer going to have all that acid. So guess what? There's going to be microbes. There could be some some kind of organism, pathogen, travels inside, notices that the stomach is no longer that acidic, and will try to make a home in there and, you know, start an infection. So you need to be aware of this, that patients that come in, you know, may have a risk for infection because of something we're doing, like that example. So these are all things you need to keep in your mind, because you'll need to recognize the cues if this patient starts to have signs and symptoms of infection, and you need to figure out why. What happened? What did we do? Okay? Okay. So moving on. Portal of exit. So all of this infectious material, pathogens, are in the reservoir, right? And we're talking about our human body, so they're in us. So we need a portal of exit. Where is this stuff going to leave the body and be transmitted somewhere else as part of this links, right? The 6 links. So a contained reservoir is only a potential source of infection. For the infection to spread, it must exit the body. So in humans, the most frequent portal is bodily fluids. So urine, diarrhea, coughing, sneezing, wounds that have a lot of drainage. Even your IV lines and tubes can be a portal of exit. So when you are working as a nurse, when you're at your clinicals and you step into a patient's room and a patient is coughing and sneezing, you need to think, wow, that's like a portal of exit. Those microbes are in there. I need to protect myself. I need to protect the patient, right? Bodily fluids. If you are changing a patient that is incontinent and wet the whole bed, when you're changing the linen, you have to keep that in mind, that this is a portal of exit. And if this patient is infectious, everything that's coming out of them is full of microorganisms. Then we have mode of transmission. So now we have our patient who's infectious. They're the reservoir. They have the portal of exit, so it's coming out of their body somehow. But then how is it going to get transmitted to the next person? So this really depends on the microorganism. So we have contact. So this is when infectious material is either touched directly or indirectly touched, like with a fomite. So direct contact is when, just as the name implies, physical contact, sexual intercourse, you're touching wound drainage. There can be an abrasion, scratching, biting, and then something is transferred, the microorganism is transferred. Or it can be indirect contact. So maybe the person sneezes on their cell phone and then you use the cell phone and then put it up to your face, your eyes, touch it with your mouth. It can go that way. And of course, we call the phone would be a fomite, which is an inanimate object. So then we have droplet transmission, and this is respiratory related. So if a patient exhales, so if they're just breathing, they're not even coughing, they're just breathing, it can come out, sneezing. If they're talking, maybe you're doing oral care, cleaning their mouth, that can cause droplets to come out and potentially transmit that infectious disease. Then we have airborne. So these are little tiny microorganisms that are so tiny and light that they kind of fly in the air. So these can kind of fly long distances, so they can, in the community, they can actually reach people for a longer distance. They're very light versus droplets that are big and heavy. Then we have a vector. So a vector is an organism that carries the pathogen and then can transfer it to a susceptible host, like a human. An example of that would be a mosquito. Then we have portal of entry. So how are these microbes going to enter our body? So we have several portals of entries on our bodies, pretty much any opening or surgical incisions. So our eyes, nose, mouth, wounds, surgical incisions, IV insertion sites, any kind of tube that we insert in the patient, like an indwelling urinary catheter, a tracheostomy, anything like that can be a portal of entry because it's going into our body. And then of course we have a bite from a vector, which is another organism that's infected that then bites us, such as mosquito or a tick. Our final link to this chain is a susceptible host. So Pathogens can go into a healthy person, and that healthy person will have an immune system to fight it off. A person who has an inadequate defense is at very, very high risk of that pathogen taking over and turning into an infection. So I mentioned age before, the very young, the very old. If you already have a compromised immune system, or maybe you have some type of immune deficiency condition, which you'll learn about later. But again, susceptible hosts, so this is the final link in the chain. So this is just another overview. So the whole takeaway about why we're even talking about this chain of infection is that there are many opportunities that you as a nurse can stop the chain. So if somebody is coughing and sneezing, then educate them on the appropriate way to cover their mouth, to avoid spreading it to their friends and family, to us at the hospital. Very simple. We want to educate patients not to drink contaminated water, not to eat that food that's been left out, 24 hours, not expose themselves to these pathogens. Education. Portal of exit. If a patient is sick with the flu, ask them to wear a mask when they go out or at home with their family. If they have a wound, teach them a septic technique to make sure they're wearing gloves, they wash their hands, they don't discard infectious material like gauze from their wound inappropriately. Make sure it's in the trash, bagged up. Those are the type of things that we can do to stop the link in this chain. So really important that you remember all these things. Then a little bit about multi-drug resistant organisms, or MDROs. So these are those super bugs that you hear about. So for example, MRSA and VRSA are two bacteria that are resistant to some of our most potent antibiotics. And this can be scary because if you have a immune compromised patient and they come down with MRSA or VRSA, there's going to be very little options for them. And maybe they do take one of the options that we have left and it may not work. So really important that we educate our patients on a couple things. So the way that we can prevent these MDROs from developing is by making sure patients follow doctor's orders and take all of the medication that they're prescribed for antibiotics. So if they're prescribed 7 days, they need to take it for 7 days, even if they feel better. Because if they take it, up to day 4 and they think, oh, I feel better, I'm not going to take it, there could potentially be some leftover organisms there that will become resistant to the medication. They shouldn't overuse antibiotics either. So if they are sick, they shouldn't think that antibiotics are going to fix them. They have flu-like symptoms and they have a virus. They shouldn't go ask the neighbor or find an old bottle of antibiotics and take it. Okay, so really important that we stress that. Another thing I want to mention here, when it comes to bacteria, many times doctors will order a culture, okay, or culture and sensitivity. They can refer to that as CNS, okay, culture. So you can take a culture of just about anything. You can take a blood culture, urine culture, a stool culture, a sputum culture, lots of different kinds of cultures. All that means is that we're taking a sample of that area, sending it to the lab, and it takes a couple days, at least 2 to 3 days, to get the result back. What they do in the lab, they provide this little swab that you took the specimen of, and they put it in a warm, moist environment. They wait for it to grow, and then that's when they stick it under a microscope to see what kind of bacteria it is. Once they have the bacteria, they let the doctor know. That way the doctor can order specific antibiotics for that specific bacteria. So here's the part you need to remember. If a patient comes in and it's kind of obvious they have an infection of some kind, the doctor is going to order a culture, right, to find out what exactly the bacteria is so that they can give the antibiotics that are appropriate. So it makes sense that if the doctor orders a culture and sensitivity, You do that first before starting antibiotics. Very important that you know this, because nobody's going to tell you this when you're a nurse, okay? It's going to be assumed that you know it. So again, a patient comes in, doctor's suspecting infection, they're going to do cultures, they're going to ask you to get the specimen, and they're going to order antibiotics. The orders are going to come at the same time. You have to do the culture first. If you do not do the culture first and you start the antibiotics and then you get the culture later, when the lab runs that culture, the results will not be accurate because you already started antibiotics, and it's going to change the number of organisms in the blood. So really important that you take the culture first, okay? And this is something that you're going to encounter later in nursing school again, and definitely in practice, because this is very common, okay? So don't forget, culture first, and then you give the antibiotics. Moving on to classifying infections. So this is important because this will determine how the infection is treated. So location, if this is a local infection, then we're going to call it local. That means it's only affecting one part of the body. If it's systemic, that means that it's in the blood or the lymph. So that means it's all over. So really important, if it's local versus systemic, it's going to affect the way that we treat it. Then we have duration. Is it acute, chronic, or latent? So if it's acute, it's going to be something that comes quickly and probably doesn't last that long. If it's chronic, it may have an insidious onset or slow development, and it can be around for much longer. Then we have latent. This refers to an infection that is present, but usually you're asymptomatic. That means you're not showing any signs and symptoms or no clinical manifestations. Next are the stages of infection. So the first stage is incubation, and that is the interval between when the pathogen enters the body and when you have your first symptom. So say, for example, your friend has the flu, and you were sitting next to your friend and they gave you the flu. So you are infected, but you don't show any signs and symptoms until 2 days later. So from the moment that you encountered your friend to when you had your first symptom, that is the incubation period. Then we have the prodromal stage. So not every disease has this stage, but this is the interval from the onset of general findings to more distinct findings. So this is when pathogens begin to multiply. So you might have some vague signs and symptoms that get a little more pronounced. So that would be those microorganisms multiplying in your body. Next one would be the illness stage, and this is when you have those clinical manifestations, signs and symptoms specific to that infection that you have. So if you have the flu, you're going to have, that runny nose, the body aches, maybe the elevated temperature. That would be your illness stage. Your textbook, the Davis textbook, refers to the decline stage, and that just is to signify, some of the pathogens are dying off. And then we have the convalescent stage. So this is when those acute findings, those acute signs and symptoms begin to fade away, and there is tissue repair, and then, you return to your baseline health. This can take, depending on the disease or infection, it can take days to months. So how does our body protect us against infection? So we have primary, secondary, and tertiary defenses. And we're going to start with primary. So primary defenses are things that every healthy human being is born with. It's not something that you need to get an immunization for or take medication for or learn how to do. It's something innate. It's something that we all have. So first up is normal flora of the body. We have normal flora in our gut, and we have it on our skin. Just the presence of it being there kind of prevents other organisms from, trying to live there too. Intact skin. So the surface of skin, of healthy skin, is tough and pretty resilient, and it prevents pathogens from coming in most of the time. So if you have an intact skin, you have a pretty good barrier to infection. Now, if you don't have intact skin, then you're automatically at risk for infection. It doesn't matter how old you are, who you are, what happened, how good your immune system is, it doesn't matter. If you do not have intact skin, that is an open door to potentially let in some type of microorganism. Then we have our respiratory tree. So this would be our trachea, our bronchi, even our nares. And those are all lined with mucous membranes. So mucous membranes are sticky, they're a little gooey, and they aim to trap things that come in that aren't supposed to go down inside our body. Debris, dirt, pathogens, and we expel them by coughing, by breathing, sneezing. Our nose has, little hairs that kind of filter the upper airway, so that helps out. There's cilia, which are tiny little hairs that are also in our nasal passages, sinuses. They're in our trachea, and they try to catch things and move it out. Again, coughing and sneezing help to get those out. So what does this mean for you? Patients who are unable to cough or to sneeze forcefully may not be able to expel those pathogens that our primary defenses are trying to get out. So for example, if you have a patient that is intubated, so they have a tube down their throat that is breathing for them, those patients cannot expel secretions on their own. Okay, those secretions have to be suctioned out by you. So if you don't suction them regularly and they have the chance to build up, that is harboring microorganisms and bacteria that the body has trapped, but it can't come out. So if you have a patient who is unable to cough and clear their secretions, they're at risk for infection automatically. Okay, so that's how you should be thinking of this through the eyes of the patient. Okay, then we have our eyes. So our eyes have tears, and our tears have enzymes in there, which is antimicrobial. So if something, gets in our eyes, then hopefully the body kind of washes them away. Same with our mouth. Saliva has enzymes. And then we talked a little bit about our GI tract already, the natural pathogens that are in our gut. And our stomach has lots of acids. So if we do ingest something, if we do eat something, even a live bug, even a big bug that you can see, not even microscopic, our stomach will, do a pretty good job of getting rid of those. Then we have our genitourinary tract and the anus. So our urine is, pretty acidic, and the urinary tract also has mucous membranes, and when it's same thing, it catches things and then we urinate and it kind of pushes it out. So these are our body's natural defenses, and when they're working properly, like in a healthy person, they're very effective. The second line of defense are our secondary defenses. So this means some microorganism has passed through our primary defenses. So let's use the skin as an example. So we don't have intact skin, and a microbe was able to enter our body through that break in the skin. So now that the skin has failed, essentially, our primary defense, we're going to go into our secondary defenses. So when that intruder comes into our skin, it will trigger lots of events. It's going to trigger phagocytosis. Again, these are things that happen automatically. We're born with it. It's a natural response. We don't have to think about it. Our body just does this automatically, which is pretty amazing. Okay, so phagocytosis. So these are special white blood cells that have a specialized job, and our body tells them to go to the site of injury, which is where this infection is, and it starts to engulf bacteria, virus, pathogen, whatever is there. Then we have the complement cascade. So this is a series of enzymes, and these enzymes, together with chemical mediators, which are another word for chemical messengers, are also aimed to bring a resistance of cells to come to the area. So you don't have to know all the details, just know that this exists, and these are all of these specialized cells coming together. Another crucial part of our secondary defense is inflammation. So inflammation, again, something that is expected to happen. We want it to happen. It pretty much can take care of most things, so we want it to happen. We're going to talk a little bit more about inflammation. And then fever. Fever is part of our secondary defense. This is an elevated body temperature. So if you see in this picture, the hypothalamus in the brain is our thermostat. That's our control center. So it is our brain that's telling our body, hey, raise the temperature, and that is to make it more inhabitable for microbes, microorganisms to come in and live there. Because if the temperature is hotter, the idea is they're not going to be as comfortable and they're going to die and get out. So again, secondary defenses, everybody has it. Yes, so next. These are tertiary defenses. So this is related to antibodies, and these antibodies are going to neutralize or destroy toxins or disease-producing organisms. So how do we get antibodies? So this is separated into a couple of subgroups. We have active immunity, passive immunity, and specific immunity. So active immunity involves our own body making the antibodies, and this is related to a couple of specialized T cells, so, namely the T lymphocytes. Then we have passive immunity. So this is when the body is not making their own antibodies and they're actually being given the antibodies. Then we have specific immunity, and this is when our immune cells kind of learn to recognize and destroy pathogens, and this is where our T cells and our B cells come in. Quite complicated process, but very, very interesting and amazing. Okay, so a little bit more about this active natural immunity. So this is when you actually come in contact with the pathogen and then your body makes antibodies against it. So if you got the flu, that's a virus. You shouldn't get that same strain of virus in the future because you already have antibodies against it. Then we have active artificial immunity. This is when we give you a vaccine and your body makes antibodies because of that vaccine, and then you are immune moving forward. Then we have passive natural. So this is the one that's a gift. This is where mom gives to baby through the placenta and through breast milk. Baby is not making antibodies, they're being given to the baby. Then we have passive artificial immunity. This is, again, the body is not making any antibodies. Instead, we're giving it to the patient intravenously through IV, okay? So when it comes to specific immunity, you'll learn more about this as you advance to Med-Surg, but these are all of our white blood cells doing their job. So the takeaway for now is that white blood cells are very important in fighting off infection. So we need to make sure we maintain and promote health when it comes to our immune system and make sure those white blood cells are available to fight off all of these potential infections. Some terminology here. If you hear the word immunoglobulin, that is antibodies. It's the same thing. So this is a picture from your textbook of humoral immunity and cellular immunity. So the first one, humoral immunity, is how antibodies are produced. And I'm not going to go through that. Cellular immunity is how cells talk to each other and assign jobs, and it's cell mediated, which means the cells are talking to each other and sending them out to, do their job. So it's really interesting, and again, you'll go more in depth in Med-Surg. Now we're talking about inflammation. So what are the 5 cardinal signs of inflammation? This should come innate to you, naturally to you. So let's see. So here are the 5 cardinal signs of inflammation: pain, erythema or redness, warmth, edema or swelling, and loss of function. So each of these signs of inflammation have a purpose in the body. The body is doing this for a reason. So the pain is to tell the brain for you to stop what you're doing and to realize that you're hurt. Okay, it's a signal to realize that the body is hurt. Erythema or redness, this is because of hyperemia. This means there are more red blood cells being drawn to the area present and you get a localized redness. The warmth is for the same reason. You have increased circulation to that area of blood, nutrients, oxygen, because that's what we need to heal, and you feel that warmth. Then we have edema or swelling. So part of that cascade that happens when an intruder or a pathogen breaks the skin or comes into the body is increased vascular permeability. And what that means is that your vessels, your blood vessels, just the walls open a little bit, and plasma from your blood is able to seep out. And in that plasma is white blood cells. So as your vessel walls open just a little bit, that plasma seeps out so that it can bring white blood cells to the injury. And that's why we have edema, because there's lots of plasma there and lots of white blood cells, our soldiers. Then we have loss of function. Again, they believe this is because the brain doesn't want you to move that affected part so that you don't cause more inflammation. So important to realize this is our body's natural response to injury and infection. As a nurse, you will need to recognize what inflammation is versus what is infection, because inflammation is expected to some degree. If you get injured physically, you can expect some inflammation. If you have any type of cell injury or death, you will expect inflammation. I'm going to give you an example. So you've heard of a myocardial infarction. So that is when there is, we'll say, a blood clot, in one of the heart vessels. And if there's a blood clot, there's a blockage. If there's a blockage of blood, that means tissue is not going to be able to get oxygen. So there's going to be cell death. Cells are going to die because they don't have oxygen. That is a myocardial infarction. So it is cell death or cell injury. That is something that will cause inflammation. Inflammation is going to happen no matter what. It doesn't matter if it's a microbe, a pathogen, or an injury. Anything that causes cell injury or cell death is going to cause inflammation. So if you have that myocardial infarction, then your heart is going to become inflamed. Just because you can't see it doesn't mean it's not happening. Okay, so inflammation. Another example is if a patient has a DVT, a deep vein thrombosis. That's a blood clot in the calf, one of the vessels in the calf. So again, that's a blood clot causing, blockage of blood, so decreased circulation. Automatically, whenever you have decreased circulation, that means there are some cells, some tissue that are not getting all the oxygen they need. So they're either going to become injured or they're going to die. This is going to trigger inflammation. That's why patients who have DVTs, when they come to the hospital, they have all the 5 signs of inflammation. They're red, they're tender, they're warm, and there's lots of swelling. Okay, so that's why there's that inflammation. So it doesn't matter at what level, the cellular level, it doesn't matter what part of the body, if it's on the outside or the inside of the body. Anytime you have cell injury or cell death, there's going to be inflammation. When you have an infection, it's going to have cell injury and cell death because that's what infection is. That's what, those microbes do. So you're going to have inflammation. So again, inflammation and infection, not the same thing. But if you have an infection, you're going to have inflammation. So when you're assessing a patient that has an infection, the body has a natural response to it. Again, and it's all for a reason. Okay, so general appearance, does the patient seem fatigued and tired? Are they diaphoretic? Is the patient complaining of having chills? Okay, so for infection, one of the things the body's going to do is it's going to trigger a fever because it's going to want to make the body inhabitable for microorganisms. So it's going to tell the hypothalamus in the brain, hey, we have a microbe here, and the brain is going to change the thermostat. It's going to make it hot. One way that the body does this is by shivering. The shivering creates heat and raises body temperature. So we don't want to promote shivering. Does the patient appear well nourished? Are their mucous membranes dry? Patient might be, fluid volume deficit, dehydrated. When you sweat, you lose a lot of bodily fluids. That's one way that a patient can lose electrolytes and fluid volume. Skin, as you know, says a lot about a patient. So how is the skin turgor? Now we're measuring elasticity. Normal skin turgor should be nice and elastic. If you give it a little pinch, it shouldn't tent, right? It shouldn't look like a little tent. It should just snap right back in place. So if you have tenting, then there's a good chance your patient is dehydrated. If the patient has a localized infection, then the skin, of course, is going to be painful. It's going to be red, edema, warmth. It may have some purulent drainage. So purulent drainage is that yellow ooey gooey, white, brown, green, yellow, thick, mucousy, can smell bad, has an odor. That is infection. Okay, purulent drainage, always infection. So if you have a patient and you're on Med-Surg and you're working 2 days in a row, and you come in the first day and the patient's wound looks great, it's closed, it's dry, it's intact, you know, textbook. You come back the next day and, you know, it looks a little reddened and the little wound edges looked inflamed and the patient's kind of grimacing whenever you move the dressing, and then you see purulent drainage. That is, you know, a bunch of red flags. That wound is infected. Okay, and again, that's not normal. There has to be something done about that. Provider should be informed. Patient will probably have some type of either antibiotics topically or maybe even by mouth. Okay, so again, purulent drainage infection is reportable. Then we have our lymph nodes. So our lymph nodes is part of our lymphatic system, and our whole lymphatic system is actually part of our immune system because it's rich in white blood cells. So sometimes when our lymph nodes are engorged or palpable, because sometimes if you have a gentle touch, you can feel some of your lymph nodes, but if you can feel them really well and maybe they're swollen on just one side, they may be engorged with white blood cells, which could mean that, you know, there's some type of infectious process going on. So when patients come in and it kind of sounds like they might have an infection, you will palpate their lymph nodes. That's part of your assessment. And then we have temperature and pulse. Again, this is something the body is going to do automatically, and this is again controlled by the hypothalamus, your temperature. Temperature is going to become elevated, so you should definitely know the normal ranges of temperature. Then we have our pulse rate. Patient's pulse rate will be elevated also, so you also need to remember what the normal range is for your heart rate. So if you are assessing a patient and you take their vital signs and you see, hey, their temperature is 100.0 and their pulse rate is 105 and they look a little pale and, you know, their mouth is very dry, hey, they might have an infection going on. So this chart is from your textbook, and we're still talking about assessment when it comes to infection. And these are common tests that may be done on your patient. So we have our white blood cell count, or WBC, with differential. You will learn what differential means at a later date. For now, let's just talk about our white blood cell count. So this is a number that covers all of your white blood cells, because if you remember, we have several different types that have different jobs, and they increase with specific organisms, actually. So right now we're just looking at a generalized WBC count. So if you have an elevated WBC, then possibly have an infection. So you'll definitely want to know what the range is for that, and that is 5 to 10,000. 5 to 10,000, again, your normal WBC count. Then we have blood cultures. So very common because we need to know what the organism is, and that's the only way to find out. So when you get your blood cultures, there are 2 tubes. You draw blood into each tube. One is for anaerobic and one is for aerobic, and they just send them off to see what grows, if anything grows, from your blood. So those are blood cultures. We have urine cultures, throat cultures, wound cultures. Like I said before, we can culture just about anything to see what organism is living there, and that takes 2 to 3, even to 4 days sometimes to put them in the incubator. Just, you know, it takes time for those little organisms to multiply and grow. Then we have disease titers. You may have had these before. I'm not sure if the school requires them. So they draw your blood to see what you're immune against already and to see if you need any additional immunizations. Then we have different blood panels for specific types of diseases. So if we're already suspecting you have something, then of course there's all kinds of specific testing that they can do. We have immunoglobulin levels, and this is related to our antibodies, so it can kind of check to see your status for your humoral immunity. We have C-reactive protein, which is CRP, which will also be elevated in presence of an infection, and this has to do with protein in the blood. Again, not something that you have to know the details on right now, but just know, simply put, when there is an infectious process going on in the body, there is more protein in your blood. So this CRP is measuring one of those components. This is the same thing for the erythrocyte sedimentation rate, or ESR. So the ESR will also be elevated. Again, this is related to the increased proteins in your blood. moving on to factors that increase the risk for infection. So this is something that you should be aware of also. So if you have a new patient that you're being assigned to, once you get the history on the patient, you talk to the patient, you can really get an idea of, what's going on or what could happen to your patient. So beginning off with developmental stage. So we know that younger patients, like infants up to young children, are more vulnerable because they have immature immune systems. They haven't been around that long, so they haven't been exposed to that many pathogens, so they haven't had an opportunity to build up that immunity yet. Then as they move on later in life, the older adult, then our immunity naturally tends to decline as well. So the younger you are, the older you are, puts you at higher risk. Then we have breaks in the skin. So this can come maybe if you have a rash and you keep itching, and it comes open like that. Maybe it's a surgery. Maybe it's from incontinence. Maybe you can't hold your bladder and your skin becomes, it always has moisture and then it breaks down that way. Maybe you had an animal bite or an insect bite. That puts you higher at risk. If you have a IV or some kind of other intravenous access, that puts you at risk. Those are all portal of entries for infectious microorganisms. Okay, we have illness and chronic disease. So when you have an infection and you're getting over it, so remember the cells that are involved for fighting the disease or infection. They're your white blood cells, and it takes a lot of energy to do that, a lot of work, a lot of resources, a lot of nutrients. So if you just got over a really big illness, during that convalescent stage, you don't have a lot of resources to fight another infection right away. So when patients are recovering from illness, during that time period, they're at high risk for getting another infection because they just don't have the resources to fight a new one, to fight a new microorganism that may be, trying to come in. Okay, we have smoking and substance abuse. So smoking is a risk factor for infection because it kind of interferes with our normal respiratory function, and it can also impede the way that you move your chest, cough, sneeze, or even have, air exchange in your lungs. So there's lots of carcinogens, chemicals in tobacco that can damage the cilia that, you remember, catch debris to help push it out. So all of these things can, allow bacteria and other microorganisms to grow in the respiratory tract. So if they're smoking, puts them at higher risk. Multiple sex partners, this is related to sexually transmitted infections. So that's a whole nother chapter. Then we have medications that inhibit or decrease immune response. So common medications like NSAIDs, which an example would be like ibuprofen, or some chemotherapy medications, or corticosteroids like prednisone. So these can kind of decrease the production of our white blood cells, or sometimes they can cause them to act a little abnormally. So that can leave the patient at higher risk for infection. Then we have nursing and medical procedures. So we're talking about when we insert things into our patient or when the patient has surgery. There's a lot of room for error there. And it doesn't just stop at, hospital or healthcare providers. It can also be the patient's caretakers at home that are doing these things. Patients who have like chronic disease, chronic illness at home, oftentimes they're discharged home, and we educate the family, the caregiver, sometimes they're doing inserting catheters to drain the bladder. So it might be something that they're doing and not following that protocol to maintain sterility, those kind of things. So we want to promote health and support our patients' immune systems. And here are a few ways that we can do that. So adequate nutrition. So providing adequate nutrition, it's giving the body the resources it needs to replenish all of those things that they had to use to fight infection, and it builds up the reserve for the next infection just in case. So very important is adequate nutrition to maintain an immune system. So how does this play into your patient? Well, if you have a patient that comes in and they haven't been eating well for months and they have had weight loss, they're going to be at high risk for infection because, you know, the cells in their body are they just don't have resources to function adequately. Okay, we have balanced hygiene. So first off, we want to encourage frequent hand washing, and bathing, showering also decreases the count on the skin. But we don't want the patients to overly do it. We don't want them to scrub off their, you know, their resident flora, because then that can leave an imbalance and can let other pathogens in. So that's going to be education there. And we don't want to cause skin cracking. So if you overly use products and you're scrubbing your hands really, you know, down to the nubs, then you can actually injure your skin and cause impaired skin integrity. So we need to educate them on that. So then we have rest and exercise. So us humans, we need rest and sleep to kind of reboot our system. So that's very important. And not everybody needs the same amount of sleep. You know, it varies depending on your age and your developmental stage. But rest and exercise are very important. Exercise releases endorphins. It's good for your health and your wellness. Reducing stress. It doesn't matter if it's physical, mental stress. Decreasing stress in your life boosts the body's immune system. If you're really stressed out and you are letting the stress kind of overwhelm you, that can make you physically ill. It can cause longer healing times. If you have an infection and you're really stressed out, that can actually impede you from getting over that infection. So reducing stress is very important. And then of course we want to promote immunization. So these are vaccines, especially with childhood diseases. We want to promote vaccines and, you know, the flu shot and the pneumococcal shot. So we want to follow the recommendations of, you know, the CDC when it comes to that, so that we don't have another epidemic. Okay, so now we're going to move on to how do we actually prevent infection when we're working as nurses. New term to learn, medical asepsis. So the textbook definition is a state of cleanliness that decreases the potential for spread of infections. So medical asepsis is pretty much anything you do, any procedure that is going to decrease the risk of spreading, you know, infections. And the number one thing that comes to mind is hand washing. So hand washing is part of medical asepsis. It's something that we can do to prevent the spread of infection. Another thing listed here is maintaining a clean environment. So this can be in the hospital, it can be a skilled nursing facility, it can be in the patient's home. This is all something that we can educate on and help the patients. So this includes, you know, clearing their side table, not having their urinal next to their food tray. This is, you know, you're changing their wound dressing and you're discarding of all of the trash, the soiled linen or the soiled gauze appropriately. Again, maintaining clean hands and following the guidelines from the CDC. You know, they have lots of guidelines. They have hand washing guidelines. I'm sure you guys have seen that. That was part of your homework. Okay, moving on. Now we have a picture of a hospital room here, and at first glance, the room is nice and bright. You know, it doesn't seem too messy. Actually looks pretty clean. But you as a nurse, as you walk into a room like this, need to remember that everything in the room is contaminated. Everything the patient touches is contaminated. So for us, you know, the bed, the rail, the linen, the side table, the call light, the patient's personal belongings, anything they brought from home, that is all contaminated, and you need to treat it as so. So you should be washing your hands after touching any of these items, before putting on your gloves, after you do whatever you're doing in the room, you take off your gloves, you wash your hands. You're always going to hear that that is so important to wash your hands, because it is, because you break that chain of infection just by washing your hands. And it's something that you can do. It only takes at least 20 seconds, right? So please wash your hands. When you walk into the room, always remember everything is contaminated in the room. You don't want to be taking things out of the room, putting them in the hallway where other people can touch, taking it to another patient's room. If you take vital signs with, you know, you have a vital signs machine, you take the vital signs of your patient, you need to wipe down that machine before going into another room. It does not matter if the patient isn't on isolation precautions. even if it's just standard precautions, you know, they're sick, but it's not an infectious, communicable disease, you still have to wipe down equipment after every use with a bleach wipe. Okay, continuing on, maintaining a clean environment. So you do want to clean up spills and dirty surfaces promptly. There are resources in the hospital. If a patient spills something on the floor, on the table, in the bathroom, you want to get that cleaned up. Use your resources, call housekeeping. You don't want those things lingering around, collecting bacteria. We want to disinfect if applicable. There's lots of wipes, okay, Sani wipes, Sani cloth, antibacterial wipes. Again, consider supplies brought to the patient's room as contaminated. So let's think about this. So patient has a wound and you go into the room and you didn't see any supplies. So you go to the supply room and you're looking at all the supplies in the room and you're like, wow, I need one of everything. So you collect all these supplies, you bring it to the room, you get set up, you open a drawer and you're like, wow, somebody already brought the supplies. So now you have all these supplies you brought plus the supplies that are in the drawer. Okay, well, maybe the patient's going to be there a while, so it's okay. But guess what? Every nurse after you does the same thing. So all of a sudden, now the patient has a supply room in their room. Why does this matter? Well, even if those packages are still closed, even if it's a roll of gauze, unopened package, it is considered contaminated. We cannot take it back out and store it. We cannot use it for another patient. It goes in the trash when the patient leaves. If the patient is going to skilled nursing facility or some other type of facility, we can send it with the patient because we know hopefully they can use it. If they're going home, we could even send it home. But even if they are closed packages, we cannot reuse them. So we really need to be careful with our resources. Now we have a whole slide on when to wash your hands. Now this seems self-explanatory. However, there are people that do not follow this, and that is why that 6th chain of infection, that is why it's still there, because people don't take the time to break the link, such as washing your hands, something so simple. Okay, so when do you wash your hands? When you get to work, when you leave work, before you put on gloves, after you put on gloves, before you eat, after you eat. If you touch anything that is contaminated, aka anything in the patient's room, wash your hands. And of course, when you see something visible on your hands that's dirty, wash your hands. Do not use hand sanitizer. If you think you're going to come in contact with bacterial spores, the big example here is C. diff. C. diff is a bacteria that lives in stool, in liquid stool. If you have a patient that has lots of liquid stool, you probably want to get it tested for C. diff. C. diff also has a very specific odor, which you'll all get to know. But again, you cannot use hand sanitizer for patients who have C. diff. You have to wash your hands. These are the 5 moments of hand hygiene. You'll see lots of pictures of this in the hospital just to remind you of when you should wash your hands. These are the guidelines per your textbook. It says wash for at least 15 seconds. We like to say 20 seconds just to be on the safe side. Again, this is talking about non-surgical. So of course in surgery, they have a different protocol. It's going to be 2 to 6 minutes if you're in the OR or a surgical procedure. You don't want to wear any rings. It can harbor bacteria. You can't really wash under that well if you have rings on. And also clean underneath your fingernails. If you're wearing bracelets, same thing. If they hang low because you need to wash at least 2 inches on the wrist, then you should remove that also. You use warm water, not hot. You don't want to excoriate your skin because you can cause skin breakdown on your own hands. You want to apply soap to wet hands. Use friction. Friction is key. Rinse soap, towel dry, and use the towel to turn off that water. This is just a little picture for you. Okay, now we're moving on to our precautions, and this is CDC guidelines, okay, Centers for Disease Control guidelines. So we have our standard precautions. This is when you are touching or treating any patient, doesn't matter what you have. We don't know what they have, okay, so we're going to use gloves. That is the minimum, gloves. Now if the patient is coughing and you want to put on a mask, put a mask on. If you think something's going to spray in your eyes, then put on goggles, put on a face shield. You can always add to it, but the bare minimum for standard precautions is washing your hands and wearing gloves, okay? This is for all patients, standard precautions. Then we have contact precautions. So these are for organisms that you need to touch, you need to come in contact with. So these aren't going to be things that are flying around. These are things you have to touch. So our minimum for contact precautions is going to be gloves and gown to protect our uniform, our body, and gloves. These patients will typically be in a private room, and we will throw away things in the room. Like, we don't want to take things out of the room, again, because everything is definitely contaminated. Here it says possibly private room. Any patient who has any type of precaution, whether it's contact, airborne, droplet, ideally we want them to be in a private room. However, sometimes that's impossible. So sometimes facilities will make, an exception. Like, for example, if you have 2 COVID patients, you may put them together in a room. If you have 2 patients with the exact same organism, they may do that. That's the exception. They really like to keep patients in private rooms. So for contact precautions, so these patients can have visitors, but they also have to put on the gown and gloves. And that is not something that they can refuse. If they refuse to do that, they cannot go in the room. These are examples here on the slide of different organisms, and your mnemonic is Mrs. Wee, so you can take a look at that. Then we have droplet precautions. So remember, droplets are heavy and big, and they come from the respiratory tract. So they're going to come out while you're sneezing, coughing, and it's going to also land on objects in the room. So you want to keep that in mind also. Again, we're going by the CDC minimum guidelines. So that is a mask, a regular surgical mask, and gloves when you're within 3 feet of the patient. Again, these are evidence-based practices. If you feel the patient is coughing a lot, sneezing in your face, then put on a face shield, put on goggles. You can always add more to it. The little disclaimer I have here, it says wearing goggles and a gown is facility policy. Whatever your facility says to do, do it. I know when I was working, the doors on the hospital patient rooms have signs that tell you what to wear if the patient's on, isolation precautions. And sure enough, droplet, all it says is a surgical mask and gloves. I always thought that was kind of strange because, things can be in your eyes. But again, we're talking about bare minimum. So yes, put on the face shield, put on the goggles if you think you need it. And here are our mnemonics for this one is Pimp and Spider-Man. So definitely review those. Now we're at airborne. So airborne again are really, really tiny little organisms, and they're very light in the air, and they just kind of fly around the air. They stay in the air for a long time. So these patients are going to need a special room. They're going to need a negative pressure room where there's a big machine that sucks the air and pushes it outside. Uses a filter and pushes it outside. They definitely need a special room. You need gloves, and you need an N95 mask. No exceptions. You have to be fitted for this N95, and different brands have different styles, so you have to be fitted for whatever brand your facility uses. It is not universal. If a patient is on airborne precautions and they need to leave the room, if they have to go to have a procedure, if they're going to surgery or something, they need to wear a surgical mask. Okay, very important, a surgical mask. Again, very similar to droplet, CDC does not require you to put on a gown or goggles. Okay, again, it kind of seems counterintuitive, like why wouldn't I just put everything on? These things are floating in the air. Again, evidence-based, they say it's not required. However, you put your N95 and you put your gloves, and if you feel you need the mask and the face shield or the goggles and the gown, then put it on. And here are our mnemonics for airborne precautions. My chicken has TB and MTB. And lastly is protective isolation. So this is when the patient has a very compromised immune system. They do not have an infection. They're just immunocompromised, meaning if they come in contact with an organism, then they will get an infection. So this is when we're protecting them from us. We want to have a private room Okay, no carpeting, daily wet dusting. That means you don't want to get a dry cloth and dust because the dust will kind of like fly into the room. But if it's a wet cloth, it'll kind of keep it to a minimum. You don't want standing water in the room that can harbor bacteria. And the nurse should not be assigned to another patient that has an active infection, because despite her best efforts, she may bring that in, or he or she may bring that in, even by washing their hands and not sharing equipment. And if a patient's on protective isolation, then they're very, very, very at risk for getting an infection. So we're going to use standard precautions plus a mask and PPE to protect the patient. So we want to wear a gown, we want to wear gloves, and a mask so that we don't infect the patient. This is also called reverse isolation or neutropenic precautions. This is really common with patients who are on chemotherapy or who have extensive burns over their body. This is just another picture you can reference. Next is our final slide on implementing surgical asepsis. So this is when you have to be in a sterile environment. This could be in the operating room or a procedure room, or partially when you are doing a sterile procedure like inserting a urinary catheter. So you'll get more practice with this later. It involves putting on sterile gloves, creating a sterile field, a surgical hand rub, all of those things. So for now, just read that in your textbook, and we'll go over later in the semester that topic. And that concludes this module.